Hello, good morning everyone. Our today's seminar is on clinical approach to multivalvular heart disease, which will be presented by Dr. Kamal Sharma sir, who is associate professor in cardiology, having 20 years of experience. Thank you. Looking forward for your kind presence.
Hi, good morning. So I'm going to take you through clinical examination approach to multivalvular disease. Basically, we require good history taking, examination and auscultation apart from investigative approach with X-ray, ECG and echocardiography. Very important to understand is what are the common causes of common cardinal symptoms. For example, common causes of angina in terms of valvular heart disease would include disorders of aortic valve disease or pericardial disease or ischemic heart disease, and sometimes rarely even mitral valve prolapse or dissection of aorta. Dyspnea, when we have to compare from cardiovascular versus respiratory etiology, couple of classical features that suggest that we are dealing with a cardiac cause of etiology of dyspnea includes classical PND and extreme diaphoresis, which is a marker of increased sympathetic tone, which is a response of the body to the failing heart. Pink frothy sputum and breathlessness preceding cough would also help in differentiating cardiac etiology of dyspnea from respiratory etiology. Again, in a patient who was previously stable, if you find a patient of valvular heart disease who is rapidly deteriorated, the causes should include and be investigated for new onset of arrhythmia, especially atrial fibrillation, infective endocarditis or rheumatic carditis, apart from deterioration in a previously stable female due to pregnancy. Pregnancy can lead to increased cardiac volume and output, and these can together be responsible through a stenotic valve to cause increased gradient and more symptoms. Anemia, infection, sepsis, hypertransfusion, or including IV fluid administration rapidly in a previously stable patient may be one of the cause of rapid deterioration in these patients. When we understand and try to evaluate various aspects and etiologies, we must be aware what are normal hemodynamics of the heart. Right atrium mean pressure is 3 millimeters, right ventricle is 25, pulmonary capillary wedge is 9, systemic vascular resistance is 1100 dyne second centimeter to the power minus 5, and pulmonary vascular resistance on mean is 70. In mitral stenosis, what happens is the LV end diastolic pressure is becoming low, LA and wedge pressure is raised. There is a chronicity would lead to a reactive pulmonary arterial hypertension, and hence the RVSP would hence be reflecting the PS systolic pressure, and RV end diastolic pressure would be reflective of right ventricle ejection fraction. Right atrial pressure would be determined by associated tricuspid regurgitation as well as will be reflective of RV end diastolic pressure. In chronic MR, because of the compliant LA, LV end diastolic pressure may rise, and the rising LVEDP would actually suggest a failing left ventricle. LA and wedge pressure both are raised, especially the V waves. V waves are reflective of a regurgitant or a compliant LA, as with the LV pushing its blood into the systole into it. So V is usually more than A in MR, and PA pressure would again be determined by the LA compliance. In the non-compliant and acute MR, you would have earlier rise in the PA systolic pressure. RVSP usually would be normal unless the pulmonary hypertension develops because of the either acute MR or patients going into LV dysfunction, or as the MR becomes chronic, the reactive changes or associated valvular lesions can lead to development of pulmonary hypertension. RV end diastolic pressure hence is reflective sometimes of organic and tricuspid or terminal disease, and hence rise in the RV end diastolic pressure is usually a terminal event. RA pressure is reflected again by TR and RV end diastolic pressure. In aortic stenosis, LV end diastolic pressure is usually low or normal, LA pressure rises slightly, and PA pressures would again remain normal, with RVSP and PA systolic being reflective of each other. RV end diastolic pressure is usually again, if raised, terminal, and RA pressure is usually normal because otherwise it would suggest associated tricuspid valve disease. Normal or narrow pulse pressure and raised LV systolic pressures are pathognomonic of aortic stenosis. Compare this with chronic aortic regurgitation, where LV end diastolic pressure is raised, LA and wedge pressures are normal or mildly raised, PA pressures are normal, RV systolic pressures, which are again reflective of PA systolic pressure, would be normal because of the proximal chamber being the LV and much much later and very rarely you would have the right-sided involvement. Wide pulse pressure is pathognomonic of chronic AR. So in a patient of valvular heart disease, what are the factors that would determine which of the multivalvular patient has got a dominant lesion? Dominantly, symptoms would help us in differentiating aortic versus mitral, and same would be the case when differentiating stenosis from regurgitation. In aortic valve disease, the dominant symptoms are angina and dyspnea. As we all know from the Brunwald series, in patients who develop angina, the survival is 5 years, syncope 3 years, and failure 2 years. Same is the case with aortic regurgitation, where syncope is rare. In patients with angina, in AR is 4 years and 2 years for patients with failure. Duration of illness hence would determine that the patients that we are dealing with do have a mitral disease or not. For example, if a patient has got dyspnea, say more than 10 years, he is more likely to have mitral stenosis than have a dominant aortic valve severe disease. Pulse characteristic would also be pathognomonic of various disorder. In mitral stenosis, pulse is usually low volume, while that in aortic stenosis, you can have either an aortic anacrotic pulse, or you can have bisvariance with associated AR, or you can have patients developing parvus et tardus or alternans when LV dysfunction supervenes. Blood pressure, whether it's a wide pulse pressure in AR or a narrow pulse pressure in AS or MS, would also be helpful in determining the severity of lesion and which is the dominant lesion in a multivalvular case. JVP would help in differentiating tricuspid disease, or will also be helpful in finding if the pulmonary arterial hypertension is present or not. If the pulmonary arterial hypertension is present, the pH would be a finding suggestive of mitral stenosis or a mitral valve disease, or patients with associated tricuspid valve disease to pick up a case of pulmonary arterial hypertension. Characteristic of apex beat, whether it's down and out or only out or it's non-displaced, would also help in determining what kind of lesion we are dealing with. Mitral stenosis would have a tapping apex beat, while an apex beat which is down and out would usually be favor of either MR or AR. Intensity of first heart sound and duration and length intensity and the characteristic of the murmurs also will help in determining the dominance of the lesion. Cardinal symptoms, mitral stenosis would be dyspnea, cough, palpitation, while that of the right heart failure would also go in favor of mitral stenosis. Mitral regurgitation would present usually with fatigue and palpitation, and aortic stenosis would have, as I said, the three classical symptoms of angina, syncope, and failure, while AR presents with angina, palpitation, fatigue, syncope, and very rarely and lastly and terminally with failure. Duration of history, as I said, in Rose series, a patient who had survived for 10 years in class 1 or 2 is more likely to be mitral stenosis with rather than aortic stenosis, because class 1 patients have mortality of only 15% at 10 years, class 2 have 58%, class 3 85%, but class 4 almost all are dead by 10 years. In Rose series, hence 10-year mortality for a mean age in its series of 28 years, 52% patients who were asymptomatic had 39%, while 20-year mortality was 79%. In Oleson's series, where mean age was 42 and 86% were symptomatic, 70% were mortality. In Rappaport series, it is 60%. Compare this with, say, mitral regurgitation, where 5-year survival in symptomatic patient who refused surgery is only 30%. In MR due to fail, the annual mortality is 6.3%, and this is again in arithmetic progression. The mild mitral regurgitation patients usually have good prognosis, while severe MR in 10 years survival, only 60% in Rappaport series and 46% in Moon series were surviving at 10 years. Flail leaflets in Link series, there was 57%, and in symptomatic patients with 5-year survival, it was 30%. When you look at the aortic valve disease, hence the expected survival in AS-based symptoms, as I said, in Brunwald series was 5, 3, and 2, and 4 and 2 respectively for AS and AR. And hence Brunwald-Ross series had compiled upon the aortic stenosis or sclerosis based survival. In sclerosis, 2.5% over 8 year develop severe AS, while progression of AS is of 0.12 centimeters square regression per year with a gradient rising of 7 millimeter per year. In Rosenhack series, if the valve Vmax was less than 4, event-free survival at 2 years was 75%, while if the peak velocity was more than 5.5, it was 25%. In Bono series in chronic AR, of the alive patients who were followed up over 6.4 years, rate of progression to LV dysfunction was 4.3% per year, while average mortality was 0.19%. Hence, in patients who are symptomatic versus asymptomatic, the symptomatics do much worse. Symptomatic mortality patients with AR is more than 10% per year, while asymptomatic LV dysfunction to symptomatic conversion is almost 25%. When you compare dyspnea preceding palpitation, it means arrhythmia is triggered by hypoxia and hence it's a cardiovascular disorder. However, if palpitation precedes dyspnea, it means a shortened cycle and it's sufficiently responsible. It's primarily as an electrical problem. History can help us in identifying arrhythmias of supraventricular nature. Post-arrhythmic diuresis and termination of arrhythmia by vomiting or vagal maneuvers helps to point out to this history being that of atrial as a supraventricular tachycardia. Irregular pounding of heart, presence of intermittent long cycle, short cycle suggest AFib, while rapid onset termination would suggest a tachyarrhythmia. Patients can sometimes have abdominal pain, which may be of multiple etiologies, and so can be anorexia. When you look at the hemodynamic correlation, class 1 patients usually have wedge less than 12 and they may have only mild venous hypertension, while class 2 patients have wedge between 12 to 18 and they have upper lobe redistribution, also called as antler sign. Class 3 patients are those whose wedge pressure will be usually in the range of 18 to 25 and they present with curly B line. Class 4 will have hence bed swing appearance and wedge of more than 25 in acute phase. In chronic, you add 5 millimeters of mercury to all of them. The spectrum of RHD in India is not a topic that we need to cover here, but we must understand that mitral alone can be occurring in 70 to 75%, when mitral plus aortic occurs in 20 to 25% of rheumatic heart disease. Tricuspid involvement in our subcontinent is common, involving almost 30 to 50%. In mitral stenosis, AFib and narrow pulse pressure is a characteristic, while in mitral regurgitation, a collapsing pulse and aortic stenosis with anacrotic bisvariance alternans or parvosit tardus, either of them may be present. In chronic AR, water hammer or alternans may be a feature. Pulse in AS hence can be pseudo-normalized in patients with associated AR, hypertension, low high cardiac output or elastic vessels in children. There are various signs, almost 30 plus signs, which are mentioned for rapid distal runoff or aortic regurgitation, which are available in various books, including one that we have authored. So you can go through them and you can see all the signs. Some of them are pretty much well known, like the Muller sign, the Traub's pistol shot, Dorozier's murmur, Hill's sign, which are commonly used. Blood pressure in mitral stenosis would have a narrow pulse pressure. In MR, it would be wide. The normal patients would have in mitral regurgitation a low diastolic pressure unless they supervene with LV dysfunction, when the diastolic pressures will start rising. In aortic regurgitation, diastolics as well as the systolic diastolic pressure may not be as low as that in MR, in AS, and in AR also, though it is low, and hence the wide pulse pressure is extremely characteristic, but systolic pressures are much higher in these patients. Lenzi's sign, which is a large venous giant V wave, is often visible in patients with TR and describe JVP pattern in TS and TR is classically that of prominent A and absent Y descent, and obliteration of X and prominent V in the fusion called as prominent Y descent. This is how we look at the JVP. You look across, flash the light across the skin of the neck of the patient and lean across the chest to look at the JVP. pH in mitral stenosis can be early in mitral stenosis with acute MR, while in chronic MR it's usually terminal. In a patient with aortic disease, if you're dealing with the patients and finding of pH, you're probably missing out on a silent mitral stenosis. Signs of PAH and hence are large AV1 JVP, signs of right ventricular hypertrophy, RV type of apex beat, loud P2 diastolic shock, RV heave, and presence of Graham style murmur or a functional TR murmur. Etiology of MR can also be used to identify what kind of MR etiology we are dealing with. In patients with rheumatic MR, it's a wide split. Narrow split in loud S1 we find in MVP. Paradoxical split of S2 you find in papillary muscle dysfunction. This is how you demonstrate parasternal heave, and this is how you demonstrate diastolic shock. S1 is usually loud in mitral stenosis. It's soft in MR. AS it's normal, in AR also it is soft. Loud S1 in MR would usually be a feature of tachycardia, MVP with MR, acute rheumatic carditis, anemia, and thin wall. Opening snap and LVS3 need to be differentiated, especially with the based of findings of PAH, loud S1 and mid-diastolic murmur. Demonstration of apex beat palpation can be done from the back like this, as is being described in Abrams. The characteristic of apex beat would be tapping in mitral stenosis, hyperdynamic in mitral regurgitation, which is often called as LV rock. In aortic stenosis, you have heaving apex beat, and in AR, it is hyperdynamic with downward and outward characteristic. In patients with mitral stenosis, opening snap, length of the mid-diastolic murmur are the features that help in differentiating mitral stenosis. Chronic MR would be featured by presence of associated mid-diastolic rumble with loud murmur which is extending with huge radiation. Aortic stenosis, a late peaking and a long murmur would suggest severe aortic stenosis, while AR would suggest with a long murmur and presence of atrial fibrillation sometimes, and Austin Flint murmur would again be a feature of severe AR. Mitral stenosis from Austin Flint can be differentiated by various findings which are beyond the scope of the time limits that we have. MDM from MS with severe MR can also be differentiated by presence of S3 versus opening snap, loud S1 which is present in patients with mitral stenosis, and presystolic accentuation which is always present and suggestive of mitral stenosis. In a patient who presents with right heart failure even without severe mitral stenosis or pulmonary edema, you should suspect an associated organic tricuspid disease. Similarly, a patient whose dyspnea is much longer than AS, you again should suspect a silent mitral stenosis. These are the findings hence which can be summarized in a tabular form by which you can differentiate severity of mitral stenosis based on dyspnea, PND, hemoptysis, pedal edema, atrial fibrillation, pulse, BP, JVP, cardiac output A2OS, interval, length of the murmur, palpable P2, RV heave and gram style murmur. Severity of MR can be hence be confirmed by wide splitting of A2P2, loud P2, palpable S3, presence of MDM, brisk carotid pulse, presence of thrill, presence of AFib, and downwardly displaced apex with sustained impulse with loud intensity of murmur, early or late systolic parasternal impulse. Severity of AS would again be a feature of palpable A2, paradoxical splitting S2, presence of S4, parvosit tardus, late peaking of murmur, long duration of murmur, low pulse pressure, high systolic pressure more than 200 actually rules out severe AS, and a picocarotid delay would suggest a severe AS. Longer S1 EC interval in presence of the first three signs individually suggests gradient more than 70, and a thrilled hence does not indicate severity of AS. Galloward dissociation is basically carotid delay is present as compared to MR. There will also be amyl nitrate which would increase its intensity, radiation to the carotids, and alteration in the intensity of the murmur with the VPC or in long cycle in atrial fibrillation would suggest that the murmur is of AS and not of an MR. A2 is usually soft in AS and hard at the base and ends with the A2 with a typical carotid characteristic impulse with associated features of apex beat, S3, S1 and flow MDM between MR and AS would help in differentiating Galloward dissociation. AR severity can be confirmed by Hill's sign of more than 60, presence of long diastolic murmur, Bispherian pulse, soft S1, presence of Austin Flint murmur, presence of peripheral signs of AR, diastolic pressure less than 50, forceful sustained apex beat which is displaced downward and outward, presence of LVS3 and presence of ejection murmur. There are certain terms like diastolic MR and systolic AR. Diastolic MR is found in acute AR and LV dyssynchrony, while systolic AR is found in ECMO and patients with AFib. Primary PR versus Gram-Stell is a murmur of PAH so it's usually associated with loud P2 and hence because of the pressure it starts immediately after second heart sound with diastolic shock, valvular click and RV heave being present in Gram-Stell murmur. So acute versus chronic AR versus AS from the systolic murmur of AR and functional and organic TR are also something that one should be aware of. Severe TR is picked up based on head bobbing, proptosis, systolic motion of earlobe, hepatomegaly, pulse, tile liver, ascites, edema and engorged neck veins. Silent carditis can occur in 2 to 8% of rheumatic fever and hence in a further evaluation you would require patients to be evaluated by ECG, X-ray, echo and cath if required. These findings are again beyond the topic of discussion today, which we can try to cover in some other discussion in some day, and hence looking at the axis, rhythm and chambers which are enlarged, pulmonary venous arterial hypertension and chamber enlargement and echocardiography will help in clinching the diagnosis. Thank you very much. Good to be connected with you. We'll be in touch for the further sessions ahead. All the best. Stay connected. Take care. Bye-bye.